without further ado, we're going to move to the next session about emerging researchers. So again, I have to tell you, emerging researcher is a misleading word. They are very experienced people. We're going to have emerging researcher presentation session and student competition. The session will run for 80 minutes, and because we are 10 minutes late, unfortunately, I'm going to cut a lot of things, so you can have more time with the presenters and less time with me. So Dr. Erin Fee will be the first to present our work. Erin, if you want to come close to us, please. Erin is an early career researcher at the University of WA. She was recently awarded a PhD. So pause and clap. There you go. Erin has done a lot of work in the space of the sole gun of obstetrician, which is called antenatal steroids. There's only one tool we have. We use it only once, and we're not very good at it. So Erin has decided to come and share the work that she has with us. Now, if you want to know more about Erin, there's 2 or 3 pages, but I'm going to cut that for you. I just asked her if she was an animal, which one would that be? She was very specific. She's a golden retriever. Thanks, Erin.
Perfect. Good afternoon. Oh, I'm a little taller. Good afternoon. My name is, sorry for the confusion, Erin Johnson, recently married. So I've just changed my name. But I'm presenting today on antenatal steroids. It's something that I'm particularly passionate about. It's something that our group has been focusing on for quite some time now. In particular, looking at reducing the dose, improving the efficacy, understanding how it affects the lungs, and how it affects preterm babies to improve outcomes for preterm babies. So today I'll present some data from a couple of studies and talk to you a little bit about that. So this research was supported by WIRF, the Channel 7 Telethon Trust, and the Sam Parent Charitable Foundation. So essentially today I'll give an overview of the context of how ANS are used, build a case for reevaluating current ANS practices, and present recent data to support a precision approach to ANS therapy. So worldwide, 15 million babies are born preterm every year. Here in Australia, 1 in 12 babies are born preterm. And being born preterm puts these babies at increased risk of neonatal mortality and morbidities associated with being born too soon, with that risk generally proportional to the degree of prematurity. So the earlier a baby is born, the higher risk of neonatal death and morbidities, and the severity of those morbidities as well. So antenatal steroids are the standard care for women at imminent risk of preterm delivery between 24 and 34 weeks gestation. They predominantly work by maturing the preterm lung by improving compliance and enhancing gas exchange. Currently, they are our most effective treatment to reduce RDS and improve survival of preterm infants. However, steroids are not innocuous agents, and we know there's a number of studies that are coming out now that are looking at adverse outcomes associated with steroids. There's studies that look at academic performance in school-aged children. They look at poor stress response. They look at behavioural disorders. They look at precursors to adult disease. They look at precursors like obesity and diabetes. We look at cardiovascular disease. And so we need to be really careful who we're giving these drugs to and when and why. And so also we start to look at this treatment where we're not really great at predicting preterm birth. And so we need to basically, we believe the maximum treatment to delivery window is somewhere between 48 hours to 7 days. There are studies that suggest benefit in extremely preterm babies before that 48 hours, in fact, before 24 hours. And there is some residual benefit beyond 7 days. But as I said, we're not very good at predicting preterm birth. And there's the study that suggests that 50% of babies actually deliver outside of that window. There's other studies that suggest that 40% actually go on to deliver at term. And these are what we call off-target treatments. So babies that derive no benefit from the treatment or didn't need the treatment in the first place. And so that's really challenging with antenatal steroids as well. The treatment population is continually expanding. There's studies now that are looking at the use of steroids for late preterm deliveries, elective cesarean at term. And so we really need to optimize this treatment if we're starting to expand who we're giving it to. And finally, response to ANS is highly variable. So with a significant proportion of preterm infants deriving no benefit from the treatment. In a sheep model of pregnancies, which is what we do our research with, we see roughly 40% of babies show no lung maturation benefit following steroids. In a clinical population, when we look at the most recent meta-analysis in ANS, we see for those born less than or equal to 35 weeks gestation, the number needed to treat to prevent one case of RDS was 19. For those born greater than 34 weeks, the number needed to treat to prevent one case of RDS was 55. So even taking into account clinical noise, the size and number of babies exposed to ANS do not drive benefit based on primary and secondary RCT outcomes. So preterm birth is complex, and a one-size-fits-all approach to ANS may no longer be sufficient. We need to focus on individualized treatment tailored to gestation, to plurality, maternal and fetal factors, and comorbidities. And we need to focus future research on targeting those that are most likely to benefit while minimizing harm. And this is one that's really important because when we talk about benefit, when we talk about the preterm population, if that benefit is reducing neonatal death, reducing respiratory distress, IVH, NEC, then the benefit outweighs the risk. When we're talking about a late preterm population or elective cesarean at term population, we see the benefit might be a reduced hospital stay, reduced use of supplemental oxygen. It might be a reduction in TTN. And we need to really carefully consider, do these benefits outweigh the risk? And do we need to reconsider our treatment population and who would benefit best from this treatment? And I think that's a really important thing we need to think about as well. So this brings me to my first study. So this is a lung maturation response on twin fetal sheep exposed to ANS. So as I said, we see a sizable amount of variation in treatment response, and we see that a large number of babies exposed to steroids but don't necessarily get a lung maturation response. And so essentially the study was trying to understand why we have a number of babies that don't respond to steroids. We don't know whether that's treatment protocols. We don't know if that's maternal or placental factors or individual genetic variation. We really don't know why those babies don't respond to steroids, and that's really important to trying to target this treatment. So essentially the aim of this study was to test whether non-identical twins will show concordant response to ANS in terms of lung development, and the hypothesis being that twin fetuses from the same mother will show the same response to ANS. So this study used 31 ewes carrying twin pregnancies at 123 days gestation. In humans, that's roughly equivalent to 32 weeks. In this study, we gave intramuscular injections of celestone, 1 dose or 2 dose. So we know celestone is our most commonly used drug, antenatal steroid used in Australia and across New Zealand as well. Here we give 2 doses 24 hours apart. So that 2-dose celestone group basically represents our current clinical treatment, but standardized to a maternal weight. And the 1-dose group basically represents those that receive 1 dose and go on to deliver before they can get their 2nd dose. And then we always have a negative control group, which receives saline only for comparison. So the first thing we did was look at lung maturation responses. We do this by looking at the 30-minute PaCO2, so the arterial CO2. We find this is a really good marker of lung maturation. It's reflective of what we see in the ventilation outcomes. It's reflective of what we see when we look at markers of lung maturation using stuff like PCR. And so basically we look at the mean of the saline groups, so the negative control group that received no treatment at all, and we take a cutoff that's 2 standard deviations below that mean. And basically what we found was that females recorded a lower mean PaCO2 value of 77 versus 97 for males, although the observed difference was not statistically significant. But we did see that 70% of females and 45% of males were identified as treatment responders. And we also saw that 48% of ANS-treated twins were discordant for response. So we've already disproved our hypothesis. We see that 48% within the same mum, we have one baby that has mature lungs and one that has immature lungs. So naturally, the first thing to do is make sure these babies are receiving the same amount of steroid or equal amounts of steroid within the same mother. And what we found was we used LC-MS analysis. This allows us to look at the beta-methysone in the fetal plasma. And what we found is that these babies are receiving the same amount of steroid. When we looked at then dividing it down into males and females, responders, non-responders, we see that they're also receiving the same amount of steroid, but we're responding differently. What's really interesting, and in this red column here, is that the 2-dose group actually had less beta-methysone in the fetal plasma than the 1-dose group, despite receiving half the amount of steroid. So we see this, efflux or transfer of steroid out of the fetal compartment as we increase the dose, which will become important in my second study that I'll talk about a little bit later. What we also saw, and what's really interesting, that in this study, in a different study, using single pregnancies, we saw that in a one-dose celestone group, the maternal and fetal plasma betamethasone was not different to this group. So there was no statistically significant difference between how much we see in singleton pregnancies and what we see in twins, which is really important as well. So by standardizing pre-ANS exposures and the post-ventilation parameters, we were able to use twin fetuses to isolate potential differences in ANS responsiveness to the level of the individual fetus. And using genomic analysis, we identified 13 SNPs or single nucleotide polymorphisms associated with 12 genes that are statistically associated with ANS responsiveness, whether that's responsiveness or non-responsiveness. When we look closer at these SNPs, we see ones that are associated with, potentially associated with development and maintenance of vascular remodeling. This one here is associated with non-responsiveness, and we see that studies suggest that it might be an association with tissue remodeling, repair, and fibrosis. We see the MET SNPs are associated with branch morphogenesis in fetal lung. We see the NR3C1, so our glucocorticoid receptor, we see association with responsiveness and non-responsiveness, and potentially impact on glucocorticoid sensitivity and receptor binding. And we also see the STAT genes are associated with lung inflammation repair. So twin fetuses response and ANS tissue levels match those of singleton fetuses, indicating twins benefit in the same way as singletons and do not require a high betamethasone dose. Taken as a whole, these data suggest that fetal genetics play a key role in dictating the functional lung responses of ovine fetuses to ANS treatment. And given the strong evolutionary conservation of several of the genes identified in the SNP analysis, these data warrant further functional studies on the variants identified in this study. This brings me to my second study. So this is a secondary analysis that builds on a previously reported study that I presented here a couple of years ago, which aimed to identify the minimum efficacious dose of betamethasone required to promote robust fetal lung maturation. So this study was part of a larger group of studies that we've done to try and reduce the dose and identify exactly how much betamethasone we need in the fetal compartment to generate robust lung maturation. And what that study did was reported that lung maturation was maximal at a fetal plasma betamethasone concentration of 2 nanograms per mil. So this group actually had, this study had 3 groups, a 0.5, a 1, and a 2 nanogram per mil. And we found that robust lung maturation was achieved with 2 nanograms per mil, equivalent to what we see in current clinical doses. To put that into perspective, current clinical regimes use 24 milligrams of betamethasone, which achieves a fetal plasma concentration of 21 nanograms per mil. So significantly higher than what we're using in this study. What we saw was lung maturation benefit proportionally degraded at 1 and 0.5 nanograms per mil. And what this study also demonstrated that higher ANS exposures may increase clearance of betamethasone from the fetal compartment. Now, when we mentioned that previous twin study, we saw the same thing. So when we're giving 1 dose versus giving 2 doses, we see a higher clearance of steroid from the fetal compartment. We're seeing that same thing, but at really low doses, which indicates that maybe we need to look at the placenta and the fetal compartment and how that's happening. So do ANS impact fetal growth by altering placental function and transport capacity? The studies, animal studies show that steroid levels reached with current clinical doses are higher than needed and may result in reduced lung development. In contrast, lower steady doses appear to work better and are likely safer for the fetus. And clinical and experimental data show current regimes disrupt placental function and transport and impact fetal growth. There's a number of studies in sheep that have shown a dose-dependent response with steroid exposure and fetal growth. We've also seen that in a clinical setting, looking at the MAX and the Actoids trial that used repeat doses of steroid, and we saw a fetal growth effect there as well. So the aim of this study was using a sheep model of pregnancy. We aimed to determine whether changes in the placental gene expression correlated with the magnitude of fetal steroid exposure. If these changes persisted at a steroid exposure below what is necessary for functional lung maturation, and placental gene or targeted liver transcript changes help explain these differences in fetal clearance and fetal growth. So this study used a sheep model of pregnancy and consisted of 4 groups of singleton fetuses, again at that same 123 days gestation, so equivalent to that 32 weeks in human gestation. Underwent surgery to install a fetal jugular catheter, which allowed us to give this constant betamethasone infusion. And then to target a betamethasone concentration in the fetal plasma of 0.5, 1, and 2 nanograms per mil. I'm seeing a couple of faces being like infusions. This is a proof of concept, essentially. This study was to make sure what do we need in the fetal plasma to drive lung maturation, then to work backwards. We need to know how much the fetal compartment needs to drive lung maturation to then develop better low-dose treatments. And then we also had a negative control group using saline only. So initially we looked at placental bulk RNA sequencing. So this is used as mRNA extracted from placental tissue and sent for bulk sequencing, which measures the average expression level of individual genes. And what we're seeing here is as we increase the dose, and even these really small doses, as we increase the dose, you're seeing a shift away. So the purple is our negative control group, so our saline group. And as we increase the dose, you're seeing a shift away in the gene expression in these steroid groups. Put simply, basically what we see is a total differentially genes expressed in the 0.5 and 1 nanogram per mil. You're seeing 400 to 500 differentially expressed genes, significantly differentially expressed genes compared to that negative control group. When we increase to 2 nanograms per mil, we're seeing 2,000 differentially expressed genes. So basically, when we look more specifically, we see KEGG processes, including DNA replication and nucleocytoplasmic transport, significantly suppressed across all treatment groups. We see metabolizing enzymes associated with steroid biosynthesis among the most significantly upregulated genes, so metabolism of the steroid to clear it from the fetal compartment. We're also seeing a difference in placental transport solute carriers. We're seeing an increase in some, so perhaps this is basically allowing for an increase of transfer or solute carrier transferring the steroid back across the placenta. But some of these solute carriers are actually being downregulated, and some of these are responsible for transfer of amino acids and other nutrients, which is obviously really important for fetal growth. So we see this potentially disrupting nutrient transfer and perhaps leading to reduced fetal growth. Again, we did some LCMS analysis, and what we saw that LCMS analysis showed a decrease in plasma liver beta-methylene levels at increasing steroid exposures. In particular, a significant reduction in the plasma liver ratio in the 2 nanogram per mil group compared to the 0.5 nanogram per mil group. When we look at the liver qPCR, so looking at particular genes in the liver, what we found was similar to the placenta, we see an increase in protein ABCB1 transport proteins, increasing the significance across all treatment groups. And we also see an increase in metabolizing enzymes, so the same thing, an increased metabolism of steroid, an increased transport of steroid, and we're seeing that same shift of steroid out of the liver in these high-dose steroid groups. The impact of ANS on the liver development is poorly understood, but evidence suggests dose-dependent effects that may impact fetal growth. In this study, we observed transcriptome disruption even at sub-therapeutic doses. So in conclusion, even low steroid exposures below clinical levels alter placental and liver transcripts linked to fetal growth. Data shows ANS cannot promote lung maturation in sheep without disrupting the placental transcriptome. And these data highlight the need for dose minimization and careful use of ANS therapy. The evidence is clear. When administered to the right woman at the right time, ANS therapy significantly reduces neonatal death and disease. Moving beyond a blanket approach to dosing and tailoring treatment to gestation, plurality, and maternal fetal risk is critical to improving outcomes for preterm infants. Finally, I just want to thank my co-investigators who I couldn't have done this study without, and thank WIRF for allowing me to present my data today. Thank you.